Hello everybody, I'm Mehmet Duray from Süleyman Demirel University in Turkey. I am one of the project members that is clinical care for electrical stimulation in physiotherapy and rehabilitation. Our project was co-funded by the Erasmus Plus program of the European Union. These are our project partners. The coordinator is in the project Pamukkale University and other members are University of Craiova, Hatay Mustafa Kemal University, Başkent Üniversitesi, Süleyman Demirel Üniversitesi, Şule State University of Applied Science, and Burdur Mehmet Akif Ersoy University. Our association partners are Turkish, Romanian, Lithuanian, and Estonian Association of Physiotherapists. I will make a presentation about regenerated nerve physiology under Module 1, Health and Denervated Muscle Physiology. I have worked with Gökhan Bayrak from Muş Alparslan University. I want to thank to him for his contribution. In the early stage of regenerative process after Valerian degeneration, as you can see in figure 1, axon regeneration and axon migration occurred, and we see an increase in the volume of the cell body. Also, altering gain expression to initiate regeneration through with signals from the injury size is seen. Antidromic electrical activity, the first signal to neuronal cells body received from the injury site. These antidromic electrical activity can open calcium channels in the early term and also affect cellular conduction. In the early period, also the nervic factors decrease, but in this period, not only neurotrophic factors are activated, but also resulting gain and protein expression differentiations initiates. And all of these defines the early regenerative process. After early process, the transport of newly synthesized structural proteins in the cell body to multi-tissues emerging from the central axon. In regeneration process, human cells can provide important support, especially for regrowth decrease as the time elapsed after injury and distance between nerve endings after increases. This means the individual struggles against time regarding nerve regeneration and functional gain. This gives a message to all health professionals. The time is very important for regeneration process. After the first stage, the clearing the myelin sheath and myelin associated glycoproteins from the environment continue by with the support of Schwann cells. In the first few hours, the expression of phospholipids secreted from Schwann cells into the injury area to destroy myelin, and after cleaning of waste matters in environment, Schwann cells form an array in the form of Wagner bonds, and a suitable environment for regeneration is prepared. I told about that In this process, not only neurotrophic factors are activated, also other factors play roles in this process. One of these are stem cells. In this process, stem cells uh, proliferate and differentiate into other cells under appropriate environmental conditions. You can see the proliferation and differentiation process in figure 2. Stem cells supports the regenerative environment in the damaged area. This is very important for us in a regenerative process. The regenerate and stem cells regenerate damaged neurons and increase the number of glial support cells. In neurochemical process, neurochemistry aims to survive, grow, and direct the nerve string to regenerate, and some of the neurochemical factors are listed by the professionals and researchers. Vascular endothelial growth factor, fibroblast growth factor, glial cell-derived neurotrophic factor, nerve growth factor, neuroglins, and interleukin 1 and 6 also. In a few weeks, nerve fibers regenerate to the proximal retrograde region of degeneration. This process is very important indicator of regeneration, and it should be forgotten that axonal growth is higher in men than women, and axonal regeneration capacity is preserved mainly with advancing age. The axonal recovery doesn't occur on with the proximal side. For a while, axons that begin to regenerate extend to target tissue, distal nerve target. And this occurs in 3 different ways. One of these is an extension within the Schwann tube surrounding the central axon. Second, the extension in the autograft or allograft, autograft and or allograft at the distal end of the peripheral nerve. And third one is extension oriented from proximal to distal, can occur in a non-neural environment. In this process, vascular change should be known by all professionals, especially the rehabilitation professionals. The greater distance between the capillaries around the peripheral nerve lower sensitivity of peripheral nerves to low oxygen conditions. Neurovascular compliance is great importance for vascularization. If a patient has higher neurovascular compliance, this means that vascularization is good and optimal. Myelin in the peripheral nerve contains molecules such as myelin-related glycoprotein preventing disrupted axon development. And in this process, in regeneration process, the clinic of the myelin sheath is vital for faster regeneration, and it must be as early as possible. Stem cells differentiate into Schwann-like cells have the potential to myelinate regenerating peripheral nerves. In this process, the responsible growth factors, some of the responsible growth factors and their functions are for neurotrophin 3. Neurotrophin 3 increases neural outgrowth in peripheral nerves. Brain-derived and neuronal growth factors don't affect developing peripheral nerve regeneration, only affect developing central nerve regeneration. Melatonin has a stimulatory effect on axonal regeneration. Glial cell-derived neurotrophic factor and neurotrophic 4 and 5 support regeneration and increase the number of regenerated axons. Doxorubicin, a chemotherapy product applied to injured site. This product reduces the scar tissue formation index and scar density in injured site. In regeneration process, we should use electrophysiological measurement in the degeneration process. In this process, if we can't take or obtain a contraction response with Faraday stimulation, these points and a complete nerve degeneration, only we obtain a protracted response to the galvanic current in this process. Intermodulations should be applied in subacute and chronic periods to determine whether axonal regeneration is achieved or not. In this process, nerve conduction velocity increases slowly, reaching only 60% of the average conduction velocity within 4 years. After 16 years, reaches only 85% on average. You see the some factors affecting regeneration. They are a type of nerve trauma. This is very important affect factor, the regeneration, complete injury caused later regeneration or no regeneration. Gender and age are really important, promoting axon regeneration through damaged nerves, providing restoration of function without surgical intervention, restoration of function by surgical intervention, anastomosis, neurotrophic trophic environment, physiotherapy and rehabilitation protocol, application of electrical stimulation with appropriate current and parameters is very important. We must use optimal frequency, duration, and amplitude. The length of space between the damaged nerve endings, the greater length affects negatively our rehabilitation process, regeneration process, and whether or not autograft is used. The forefront factors limiting nerve recovery are loss of sensor nerve function, smoking, pulse, Schwann cell phenotype, aging of Schwann cells, inflammation, increased gap length, necrosis, increased time between nerve injury and repair, loss of neuron regeneration ability. Also, decreased improvement with patient age, excessive or incorrect application of electrical stimulation, concomitant vascular injuries, and nutritional deficiency. In this process, if we talk about functional neurotrophic factors, we need sufficient amount of neurotrophic factors, especially The sufficient amount of endogenous neurotrophic factor is necessary to support nerve regeneration. The distal stump in contact with regenerating axons further increases neurotrophic factor release, and in this part, Schwann cells plays very important role. Schwann cells segregates all growth factors, including nerve growth factor, support regeneration, and these growth factors support regeneration by upregulating neuronal cell adhesion molecules. Also, neurotrophic factors promote development and maturation and affect the regeneration of neural activity. Neurotrophic factors, especially nerve growth factor, BDNF, neurotrophin 3 and 4 are stays in the target tissue and transported retrogradely to the neuron's posterior surface. And other growth factors or neurotrophic factors are ciliary neurotrophic factor, leukemia inhibitory factor, and glial growth factor. Ciliary neurotrophic factor ensures the survival of motor neurons following axon destruction, while BDNF is upregulated. Leukemia inhibitory factor ensures the survival of sensor and sympathetic neurons, and glial growth factor myelinase sensor and motor Schwann cells stimulates cell proliferation and ensures their survival. In regeneration process, functional sensor return is very important, but this topic is not focused by the professional, not necessary interest is given to sensory recovery. We know that the regeneration of sensor appearance also is responsible or also has contribution on coordination of muscle function, regulation of reflex activity, and tone. Actions are directed to the target through neurotrophic factors, we know, and actions that are regenerated in the absence of the target either form neuromas or cause abnormal stimulation of faulty targets. If we don't use or if we don't provide optimal sensorial function in the patient, the high activation of autonomic fibers resulting hypersensitization, and this problem doesn't solve very easily. For functional motor return, not only neurotrophic factors are responsible, but also expression of regeneration-related genes is responsible in this process. P2X receptors are involved in synaptic transmission, neuromodulation, and neuroinflammatory response. The secretion of neurotrophic factors also promotes neuronal survival and positive synaptic plasticity, and BDNF provides cellular myelinization. As well as the early-term change, we see the long-term change in regeneration process. In 3 weeks after injury, motor neurons sometimes splitting to appropriate motor neurons and sometimes to inappropriate motor and sensory fibers. The inappropriate combination remains fixed after 3 weeks if it cannot be changed. After NNA levels of motor neuron specific neurotrophic factors within 2 weeks, motor neurons that remain intact spread toward the appropriate motor neuron within 10 weeks. Neuroplasticity process is very important. We told about this in a previous presentation. In the generation process, we told about regeneration plasticity or named maladaptive plasticity. That are these are very important and negative process. In the degeneration process, permanent and rapid changes are seen, and in this process, both appropriate and inappropriate axon splitting, a compensation process is started for innervation errors, and this is called denervation plasticity or mode of the plasticity that reflects very negatively on regeneration, as I said. In regeneration process, antegrade or retrograde conduction for the formation, growth, elongation, and direction of new axons, stem cells that differentiate into structures similar to Schwann cells and support neuron survival. High amount of protein synthesis for development of growth cones that facilitate axonal splitting and cleaning the inflammatory residues in the post-injury area, and it is seen that the regeneration process reaches at a rate of 1 millimeter per day and under optimal condition. If we talk about energy consumption and mitochondrial behavior in a regeneration process, in this process, regenerated axons exhibit strong regenerative capacity, and mitochondrial density increases, and increased mitochondrial density supports the regeneration, reduce oxidative stress. At the same time, increased mitochondrial division, increased mitochondrial capacity, and accelerated axon healing. If regeneration delays, we meet with prolongation of denervation, collagenation of distal stump, loss of motor implant from fibrosis tissue, and reduces the regeneration potential. If axotomy is prolonged and becomes chronic, the regenerative capacity of neurons decreases to 33% of normal in a 6-month period. And this prolonged process cause in long-term denervation and disease, prevent the functional recovery. That is the biggest obstacles in front of the functional recovery. Yes, you see more information, you find more information in our references and find in our book in related chapter. I want to thank to all of our partners and to you for listening. Thank you.